Good morning to one and all. Today we will see about deep caries management. So what is dental caries? It is defined as a multifactorial, transmissible, infectious oral disease which is caused primarily by the complex interaction of cariogenic oral flora with fermentable dietary carbohydrates on the tooth surface over time. So one of the basic steps in a restorative procedure is removal of this carious dentin. Unfortunately, this procedure is still empirical, which results in great deal of inconsistency. For the deep caries management, we have to have thorough knowledge about soft dentin and firm dentin. Soft dentin is nothing but the necrotic dentin, which is not painful to the stimulation and it is grossly infected with bacteria. And the collagen in this dentin is irreversibly denatured, so that it should be excavated with hand and the rotary instrumentation. Moving on to the firm dentin, it is a demineralized, discolored dentin which is hard in texture, but it is painful to stimulation. It contains very few bacteria. The organic acid attacks the mineral and the organic contents of the dentin, and the collagen crosslinks in this dentin remains intact, which can serve as a template for remineralization, so that this dentin can be left on the tooth. Moving on to the various treatment modalities, they are direct and indirect pulp capping. So what is indirect pulp capping? It is a procedure which is performed in a tooth with a deep caries lesion adjacent to the pulp. Here, all the infected caries dentin is removed, leaving behind the soft caries dentin adjacent to pulp so that it avoids pulpal exposure. It is indicated when there is deep caries lesion near the pulp tissue but not involving it, and when there is no mobility or no history of spontaneous toothache. There should be no signs of tenderness to percussion and no radiographic evidence of pulp pathology and no signs of root resorption or radicular disease. And it is contraindicated in cases where there is radiographic evidence of pulp pathology or history of spontaneous toothache, or when the teeth is sensitive to percussion, or when there is mobility or signs of root resorption or radicular disease. So coming to its treatment protocol, it can be done in two appointment or single appointment, and in a two appointment procedure, in the first sitting, we isolate the tooth under rubber dam to prevent the cross infection, whereas the cavity outline is carried out using a high speed handpiece, and the infected dentin can be generally removed with a hand instrument, that is a sharp spoon excavator. Cohen has also recommended a large round burr for this procedure. After the complete removal of the infected dentin, we place a hard setting calcium hydroxide over it, and the remaining cavity is reinforced with zinc oxide eugenol or GIC. This seal should not be disturbed for a period of 6 to 8 weeks so that the deep layer gets arrested. After 6 to 8 weeks, that is in the second sitting, we carefully remove all the temporary filling, especially the calcium hydroxide dressing. We can observe that the color changes from deep red rose to a light green, and there will be a change in texture from spongy to hard, and the caries dentin will appear dehydrated and flaky. This should be removed. Do not disturb the predentin, which is the area which is potential for exposure. It might appear whitish or soft. After removal of this, the remaining cavity can be reinforced and restored in a similar way as in the first sitting. And in a one appointment technique, we excavate the caries as close as possible to the pulp, and some caries is left to avoid the pulp exposure. And over it, we place the protective liner, the most commonly used is calcium hydroxide, and the remaining cavity is reinforced with GIC or GIC and then composite. Moving on to the direct pulp capping, it is a procedure which is done when there is a small mechanical exposure of pulp occurs during the tooth preparation or following a trauma. Here, an appropriate base should be placed in contact with the exposed pulp tissue so that to maintain the vitality of the remaining pulp tissue. It is indicated in case when there is a 0.5 mm or pinpoint exposure of the pulp, and when there is no signs of profuse hemorrhage, or in cases of trauma which is few hours old, and when there is no tenderness to percussion, or when the exposure site is completely aseptic. It is contraindicated when there is wide pulpal exposure, or when the tooth is periodontally involved, or when there is signs and symptoms of irreversible pulpitis, and when there is radiographic evidence of pulp pathology. So the clinical procedure is similar. We administer LA and then we isolate the tooth under rubber dam, and the vital and the healthy pulp is exposed. Check for the fresh bleeding at the exposure site and clean the area with distilled water or saline and then dry it with a cotton pellet. Now, apply calcium hydroxide over the exposed area and give an interim restoration such as zinc oxide eugenol for a period of 6 to 8 weeks. After 2 to 3 months, remove the cement and gently inspect the exposure site. If there is formation of secondary dentin, restore the tooth permanently with a protective base and then a restorative material. If there is no favorable prognosis, you might have proceed to pulpotomy. If not, you can even proceed with pulpectomy if required. So there is always a dilemma whether to re-enter or not. Re-entry is still questionable because it comes with its limitations. When the patient is asymptomatic on recall, the restoration should be redone. So it is recommended only if the patient is asymptomatic and the surrounding soft tissues are free from swelling, and if the temporary filling is intact and the bite-wing radiograph show signs of or presence of reparative dentin. Re-entry is risk because there might be chances of pulp exposure or further insult to pulp. If a pulp exposure occurs during this re-entry, a more invasive vital therapy is required such as direct pulp capping or pulpotomy. So what determines the success of this vital pulp therapies? It depends on age of the patient, type of exposure, history of pain and size of exposure. So, the extent of the pulp exposure determines the success of the treatment. There will be a successful repair when there is pinpoint exposure and sound dentin at the periphery, whereas the repairability is doubtful when the exposure site is infected at the periphery, and it is considered beyond repair when exposure is accompanied with profuse hemorrhage, and there is lesser repairability locally when there is diminished availability of nutrients in cases such as when the exposure is near anatomical constrictions. So to conclude, preserving the vitality of the pulp is the core of operative dentistry, and it offers a biological based concept which reduces the intervention and maintains the pulp's developmental, defensive and proprioceptive functions. And vital pulp therapy is technically easier to carry out than RCT. Thank you.